Hello dear students, welcome back to my channel. I love pharmacology. In continuation with the immunosuppressive agents, in this session let us learn about the common adverse effects caused by immunosuppressant therapy and let us summarize the immunosuppressant agents. So the most common adverse effect is it will going to increase the opportunistic infection, it will going to increase the bacterial infection, fungal infection and viral infection, and more commonly it will going to cause cytomegalovirus infection. So why there will be opportunistic infection or the infection related to bacteria, fungal and viral? Since there is a decrease or inhibition of both the cellular mediated immune response as well as the B cell mediated immune response, the immune system will be very weak. In such circumstances, there will be increased risk of infections. So next, these immunosuppressive agents can lead to lymphomas and secondary malignancies. So next, just to summarize, so these are the basic things. So whenever the antigen presenting cell, that is macrophage, will help in attaching the antigen along with the major histocompatibility complex 2 to the T cell receptor located on the helper T cells. You also have CD4 as well as CD3 surface receptors on the helper T cells. Once there is activation of T cell receptor, there will be increased tyrosine kinase activity, which will going to phosphorylate the phospholipase C into phosphorylated phospholipase C, which will going to cause release of the phosphatidyl inositol bisphosphate, which will going to release the diacylglycerol as well as the inositol triphosphate. Diacylglycerol will going to release the protein kinase C, whereas inositol triphosphate will going to increase the intracellular calcium levels. Along with that, there will be addition of calmodulin. This calmodulin as well as calcium complex will going to activate the calcineurin, and this calcineurin will going to dephosphorylate the nuclear factor of activated T cells, and there will be release of the NFAT. This NFAT will be translocated into the nucleus, where there will be a transcription of the cytokine interleukin 2 genes. So there will be release of the specific mRNA, that is interleukin 2 mRNA, and there will be release of the interleukin 2. And this interleukin 2 will going to bind to the interleukin 2 receptor located on the surface of the helper T cells and leading to proliferation of the T cells. Along with that, this proliferation will also be enhanced by mTOR activity. And there are targets for preventing the proliferation of T cells. You have got cyclophilin. To cyclophilin, the cyclosporin will be attaching to cyclophilin, which is a immunophilin, and this complex will going to inhibit the calcineurin activity. On the other hand, we have got tacrolimus will going to combine with the FK binding protein, and this complex will going to inhibit the calcineurin activity. And there is a sirolimus, which is a mTOR inhibitor, which will inhibit the mTOR activity by combining with the FK binding protein, and therefore it inhibits the mTOR activity. And you have got miromonab, that is CD3, which will going to inhibit the CD3 activation. So basically they are used in preventing acute transplantation rejection reaction, steroid resistance cases, bone marrow transplant patients. And miromonab, please remember, it can produce cytokine release syndrome. So basically these groups of drugs are useful in prevention of rejection during organ transplantation as well as in the treatment of autoimmune diseases. So just to summarize the immunosuppressant drugs, you have got calcineurin inhibitors. Example is cyclosporin, tacrolimus,